41% of older adults have radiographic signs of hand osteoarthritis,
Mm,
but only 3% actually feel it.
right. It's wild.
Yeah, today we are figuring out why your patient's x-ray looks like an absolute disaster, but their hand feels perfectly fine and, exactly what to do when the pain finally hits. Welcome to this high-yield revision deep dive. If you're listening to this, you're gearing up for your plastic surgery board exams, specifically the FRCS, and you need the absolute highest yield, no fluff breakdown of the clinical management of upper limb arthritis.
Absolutely.
Today, we are zeroing in entirely on osteoarthritis, or OA. We are going to cut through the noise and give you a rapid-fire Q&A style clinical interrogation of the exact pathology, the diagnostic criteria, and the surgical management strategies you need to have memorized.
Exactly. We are skipping the broad philosophical overviews today and getting straight to the mechanics, the clinical staging, and the surgical decision-making that examiners love to test. You really need to understand the logic behind the knife.
Yeah, for sure. But real quick, before we jump in, a direct request to you, the listener. Hit the follow button right now wherever you are listening. And if you find this revision session valuable, leave us a rating. Also, to truly bulletproof your exam prep, you need to get a premium subscription to the show. That gives you exclusive access to our dedicated journal club and clinical cases deep dives. You need that higher order synthesis for the boards.
That's something.
All right, the housekeeping is done. Okay, let's unpack this. Before we can surgically reconstruct a joint, we have to understand exactly what is failing at a cellular and clinical level. Delineate OA from other rheumatic disorders for us, and right out of the gate, I want you to address that fascinating statistical contradiction I mentioned at the top. Like why that massive gap between 41% with radiographic signs and only 3% with actual symptoms.
Yeah, it's a brilliant paradox, and understanding the why behind it is really the key to answering clinical vignette questions. So first, let's categorize the pathology. When we evaluate arthritic conditions of the upper limb, we are looking at three distinct pathophysiological buckets.
Okay.
You have inflammatory arthritis, that is your rheumatoid, psoriatic gout, and pseudogout. You have infective arthritis, primarily septic arthritis. And then you have degenerative arthritis. That's the bucket osteoarthritis sits in. The defining characteristic here is the mechanical and enzymatic destruction of the articular hyaline cartilage.
Even though it has that "-itis suffix, right, which implies an active inflammatory process.
Right, which is highly misleading, honestly. Mild synovitis or inflammatory joint effusions can be present during acute flare-ups, but the core pathogenesis is entirely degenerative. It's a wear and tear phenomenon, largely idiopathic in nature, though, and for the boards you must remember this. You have to look out for secondary causes like trauma, instability, or a pre-existing inflammatory arthropathy. But to answer your question about the 41% versus 3% statistic, what's fascinating here is the osteophyte formation. We're taught to view osteophytes as the physical manifestation of the disease itself, like they are the bad guys.
Right.
But from a biomechanical standpoint, that process is actually the body's natural repair mechanism. When the articular cartilage degrades, the joint becomes unstable. So the adjacent bone remodels and forms osteophytes at the synovial joint margins to increase the surface area and physically block abnormal translation.
Okay, let me use an analogy here to see if I have the biomechanics right. It's like looking at an old, structurally failing building that an engineer has retrofitted with massive, ugly steel braces bolted all over the outside.
Yeah, that's a good way to put it.
If you just look at the building's blueprint, or in our case, the x-ray, it looks terrible. It looks like a structural disaster. But those ugly steel braces are exactly what is keeping the building stable and preventing a total collapse, which is exactly why a patient can walk into your clinic with dramatic, horrific-looking x-rays, but have a stable, completely pain-free pinch grip.
That is exactly it. That is a perfect way to visualize it. The joint is effectively autofusing or stabilizing itself. And, to push your analogy further, sometimes those steel braces start rubbing against the building next door or impinging on a nerve, which is when the patient finally feels it and we have to step in surgically.
Ah, that makes total sense.
Yeah. Alongside those osteophytes, you will also see subchondral sclerosis and cyst formation as the bone responds to the altered load transmission. But because of this natural stabilization, you absolutely cannot rely on the X-ray alone to make a diagnosis or indicate surgery.
Which brings us to the actual clinical working diagnosis criteria. If the x-ray is deceptive, what are the strict pillars the examiners are looking for?
For the boards, your clinical working diagnosis rests on three non-negotiable criteria. 1. Persistent joint pain that is worse with use and relieved by rest. 2, the patient is over 45 years of age. And 3, morning stiffness lasting no more than half an hour.
Wait, let's pause on that third point. Why the strict 30-minute cutoff for morning stiffness?
Because that is your primary clinical discriminator from rheumatoid arthritis. In inflammatory arthropathies, inflammatory exudate pools in the joint capsule overnight, and it takes the patient hours of movement to pump that fluid out and regain mobility.
Oh, right.
Yeah, whereas in OA, the stiffness is purely mechanical gelling of the joint surfaces, which typically works itself out in 15 to 20 minutes of movement. Furthermore, you must establish an absence of systemic inflammation, so you should not have raised ESR or CRP levels.
Right. So we have a patient who meets the clinical criteria, but the reality is not all osteoarthritic joints are created equal. The fingers and the base of the thumb are going to walk through your clinic door with completely different trajectories. The DIPJs and the basal thumb joints are the most commonly affected areas. Why is it that IPJ-OA is relatively forgiving, while basal thumb OA is just an absolute functional disaster for the patient?
It comes down entirely to the anatomical demands of the kinetic chain. IPJ-OA actually has a highly favorable natural history. Because the interphalangeal joints only move in a single hinge plane, once the osteophytes form and the joint stiffens, the stabilization succeeds.
So it basically fixes itself.
Exactly. The pain burns out, and the joints become asymptomatic after a few years, leaving the patient with functional, albeit bumpy, fingers. But basal thumb OA is a totally different beast. The trapeziometacarpal joint is a highly mobile saddle joint subjected to immense multiplying forces. I mean, a simple 1 kilogram pinch grip translates to over 12 kilograms of force across that small articular surface.
Wow. And when that cartilage wears out under that immense load, it leads to a very specific clinical deformity that is a favorite on the exam, the shouldering effect.
Exactly. As the volar beak ligament attenuates and the cartilage degrades, the first metacarpal base subluxes dorsally and radially off the trapezium. This creates a visible shouldering or squaring at the base of the thumb.
Right.
But mechanically, because the base of the metacarpal is subluxing and adducting, the thumb can no longer open wide enough to grasp objects. So to compensate for this adducted posture, the patient's kinetic chain adapts by forcing the MCPJ into severe hyperextension just to get the thumb out of the palm. Oh, for the exam, always remember to look out for a positive grind test here.
Here's where it gets really interesting and where we hit guaranteed exam territory. Staging.
Yeah.
You cannot discuss basal thumb OA or formulate a surgical plan without the Eaton staging system. I want a rapid-fire breakdown of the 4 stages, but I want to know exactly why the parameters are set where they are.
You need to know Eaton cold, stage 1. The articular contours are completely normal. You might see slight joint space widening.
Widening, not narrowing.
Right, widening. Why? Because early on, the joint is just experiencing inflammatory effusion and ligamentous laxity, pushing the bones slightly apart.
Okay, got it. Stage 2.
Stage 2. You start to see slight narrowing of the trapeziometacarpal joint. The key measurement here is that osteophytes, or loose joint debris, are strictly under 2 millimeters.
Under 2 millimeters.
Yes, this 2 millimeter cutoff is crucial because it indicates the disease has not yet caused massive structural collapse. And critically, the scaphotrapezial joint remains entirely normal.
So what happens in stage 3?
Stage 3 is where structural failure happens. The trapeziometacarpal joint space is markedly narrowed or obliterated. You have cysts, subchondral sclerosis, and dorsal subluxation of the metacarpal. The debris is now over 2 millimeters, but, and this is key, the scaphotrapezial joint is still normal.
Okay, so the STT joint is spared in stage 3, which means stage 4 is...
The defining feature of stage 4 is disease progression across the carpus. You know, the complete deterioration of stage 3 PLUS. The scaphotrapezial joint is now narrowed with sclerotic and cystic changes. The disease is no longer isolated to the thumb base.
Perfect. So the key differentiators to memorize. Stage 2 is under 2 millimeters of debris. Stage 3 is over 2 millimeters. Stage 3 has a pristine scaphotrapezial joint. Stage 4 has a diseased scaphotrapezial joint. Now that the disease is staged, let's shift directly to the operating room. We are skipping the non-operative management, the NSAIDs, the splinting, the capsaicin, the injections. You are surgeons, the boards test the knife. We have 3 basic operative strategies: arthrodesis, arthroplasty, and osteotomy. Let's start with the fingers. Give me the exact fusion angles and the preferred techniques for the DIPJ, the PIPJ, and the MCPJ.
Let's run down the cascade. For the DIPJ, arthrodesis is the gold standard. You approach dorsally, preparing the bone surfaces with either a flat cut or a cup and cone technique to maximize cancellous bone contact and rotational stability.
Right.
You fix it with K-wires, headless compression screws like a Herbert screw, or tension band constructs. The fusion angle is between 0 and 20 degrees of flexion. Why that range? It depends entirely on the patient's occupation. A mechanic might need more flexion to grip tools, while someone doing fine desk work might prefer it straighter.
Moving proximal to the PIPJ, the angles change dramatically here, don't they?
They have to.
Yeah.
If you fuse all the PIPJs at the same angle, the patient cannot form a functional power grip. The angles must increase as you move linearly across the hand. You fuse the index finger PIPJ at 40 degrees, and you increase that sequentially up to 55 degrees for the little finger. Think about holding a cylindrical object like a hammer handle. Your little finger has to flex much tighter around the base of the cylinder than your index finger does near the top.
Now, I want to push back on PIPJ arthroplasty. Why is replacing the PIPJ considered so controversial in osteoarthritis? I mean, we do joint replacements everywhere else in the body with great success.
This raises an important question about the profound difference in soft tissue envelopes between osteoarthritis and rheumatoid arthritis. PIPJ arthroplasty using Swanson-type silicone elastomer implants is highly controversial in OA because of the failure rates.
What exactly is driving that failure?
In rheumatoid arthritis, the disease is systemic. The surrounding tendons, muscles, and ligaments are uniformly attenuated and weak. When you put a silicone implant into an RA hand, the soft tissues do not exert massive shear forces across it.
Oh, I see where this is going.
Yeah, in osteoarthritis, however, the disease is isolated to the cartilage. The patient still has strong, healthy, vigorous flexor and extensor tendons pulling with immense force across that joint. Those strong tendons literally tear the silicone implant apart, leading to early mechanical failure and silicone synovitis.
So what is the board-approved surgical algorithm if a patient has severe OA across all their PIPJs?
You use the hybrid strategy. You arthrodese, or fuse, the radial digits, the index and middle fingers, to provide a rigid, stable pose for lateral pinch. Then, you use arthroplasty for the ulnar digits, the ring and little fingers, to preserve the range of motion necessary for a wraparound power grip. Stable pinch on the radial side, flexible grip on the ulnar side.
Perfect. Let's finish the digits with the MCPJ.
For the finger MCPJs, arthroplasty is actually the preferred route. Arthrodesis is merely a salvage procedure, usually around 25 to 40 degrees.
Yeah.
But the thumb MCPJ is the exact opposite. If the thumb MCPJ is failing, you fuse it.
And the angles for that.
The classic fusion positioning you must commit to memory is 10 to 20 degrees of flexion, 20 degrees of pronation, and 20 degrees of abduction. Those specific angles are required to maintain the thumb in a functional position for opposition against the index finger.
So what does this all mean when we move proximally to the climax of the upper limb arthritis syllabus, the basal thumb joint? A patient presents with severe bone-on-bone basal thumb OA. They are in agony. How do we definitively choose between an osteotomy, an arthrodesis, or an arthroplasty?
Let's tackle them chronologically by disease state. First, the abduction-extension osteotomy of the first metacarpal base. The mechanical goal here is to alter the biomechanics to offload the worn palmar compartment of the CMCJ and shift the forces to the healthier dorsal cartilage.
But does anyone actually do that anymore?
And in reality, it is exceptionally rare. By the time patients seek surgical consultation, their cartilage is entirely gone. It is reserved almost exclusively for high-demand young manual laborers with very early stage 1 or mild stage 2 disease.
Okay, next option, arthrodesis of the basal joint.
Arthrodesis is an incredibly powerful tool for post-traumatic OA. If you have, say, a 35-year-old construction worker with a malunion of a Bennett's fracture, a fusion gives them a painless, rigid pillar to hammer and lift with. But here is the critical trap for the exam. Arthrodesis fixes the thumb in a rigid, abducted, and opposed position. It is permanently fixed out of the plane of the palm.
Right.
You must explicitly warn the patient during the consenting process that they will never again be able to place their hand completely flat on a table. They will no longer be able to do traditional press-ups. If an exam question asks about preoperative counseling for a CMCJ fusion, flat hand placement and press-ups are the mandatory answers.
Which brings us to arthroplasty, specifically excision arthroplasty, the trapeziectomy. This is the undisputed gold standard.
Correct. For the vast majority of your symptomatic patients, trapeziectomy is a definitive answer.
But I am going to play devil's advocate here. Hand surgeons love complex, elegant modifications. We read constantly about concerns regarding proximal migration of the metacarpal and thumb shortening after you excise the trapezium. What about performing an LRTI, a ligament reconstruction and tendon interposition, using the APL or the FCR tendon to create a suspension sling? Or what about placing temporary K-wires to distract the joint and maintain length while the scar tissue forms? Surely these complex reconstructions yield better functional results than just leaving an empty void.
If we connect this to the bigger picture and examine the randomized controlled trials and Cochrane reviews, the answer is remarkably blunt. Absolutely nothing has been conclusively shown to be superior to a simple trapeziectomy.
Nothing at all. All those tendon weaves provide no biomechanical advantage.
None. The LRTIs, the interpositions, the K-wire suspensions, they were all theorized to prevent shortening and thereby preserve pinch strength. But the clinical reality is that a simple trapeziectomy allows the void to fill with a dense hematoma, which organizes into robust scar tissue. That fibrous pseudarthrosis provides excellent pain relief and functional strength that is statistically indistinguishable from the complex tendon weaves.
Wow.
Yeah, and furthermore, those complex procedures carry a significantly higher complication rate. You have longer operative times, harvest site morbidity from taking the FCR, higher risks of nerve injury, and hardware complications. For the boards, keep it simple. Trapeziectomy is your answer.
However, we know trapeziectomies can fail. If a patient returns to your clinic 6 months post-op and they are still wincing when they pinch, what is your differential diagnosis for that surgical failure? Like, what did we miss?
There are 4 specific mechanisms of failure for a trapeziectomy that you need to systematically evaluate. First, incomplete excision. The trapezium sits deep, and it is very easy to leave a small volar or ulnar osteophyte behind. If you leave a bony fragment, it will grind painfully against the scaphoid or the base of the metacarpal during pinch.
Okay, that makes sense. Number 2.
Second, a neuroma of the superficial radial nerve. The SRN branches run directly over your dorsal radial incision line, and they are notoriously sensitive to traction injury during retraction.
Third.
Third is a collapsing pinch due to unaddressed MCPJ hyperextension. We discussed earlier how CMCJ disease forces the NCPJ to hyperextend to compensate. If you remove the trapezium, you destabilize the base. If the patient has a severely lax MCPJ that you ignored during the primary surgery, their entire pinch mechanism will buckle and collapse postoperatively.
So how do you handle that?
You have to stabilize that MCPJ concurrently, either through an EPB capsulodesis, a volar sesamoid tenodesis, or a formal MCPJ fusion.
And the fourth and final reason they are still in pain.
Missed pantrapezial OA. You assumed it was stage 3 disease and only removed the trapezium, but it was actually stage 4. The disease had already spread to the scaphotrapezial joint. This requires careful preoperative clinical distinction between pure scaphotrapezial trapezoid, or STT-OA, and pantrapezial OA.
How do you tell the difference clinically?
Pure STT-OA primarily causes pain on wrist deviation, while pantrapezial OA causes pain on movement of both the thumb and the wrist. If they have pure STT-OA, you treat it by excising the distal pole of the scaphoid. Attempting an STT arthrodesis is technically demanding, frequently fails to maintain carpal height, and almost inevitably shifts the stress to cause radioscaphoid OA down the line.
Okay, let's synthesize everything we've pulled apart today so you can lock it in for the boards. This was dense, but here are your non-negotiable takeaways. Number 1, trust the clinical diagnostic criteria over the X-ray. Remember the analogy of the building with the steel braces. Radiographic destruction does not equal clinical pain. Number 2, memorize your Eaton stages, specifically knowing that the scaphotrapezial joint only gets diseased in stage 4 and your debris cutoff is 2 millimeters. Number 3, for the PIPJs, you must use the hybrid approach. Fuse the radial digits to provide a rigid post for lateral pinch and replace the ulnar digits to maintain the sweep of the power grip. Number 4, know the exact biomechanics of your fusion angles, particularly that increasing cascade from the index to the little finger. And finally, number 5, for the basal thumb, despite the allure of elegant tendon weaves, the simplest operation, the trapeziectomy, remains the gold standard.
It is a massive amount of surgical mechanics to absorb, but if you understand the why behind the what, you will not have to rely purely on rote memorization. I want to leave you with a final thought to ponder as you continue your revision. Think deeply about how a collapsing basal thumb joint forces the distal MCPJ into hyperextension. It is a perfect reminder that in the upper limb, you can never evaluate a single joint in isolation. Altering the biomechanics at one note, whether through progressive degenerative disease or through your surgical intervention, creates an unavoidable domino effect across the entire kinetic chain of the hand. If you meticulously excise the trapezium but ignore the collapsing MCPJ, your patient will still struggle to turn a key. Always look at the system, not just the symptom.
That is exactly the kind of higher level surgical philosophy the examiners are looking for. To you listening, keep that domino effect at the forefront of your mind the next time you're examining a hand in clinic. We want to hear from you. Leave a comment or a question about this material wherever you are listening to this deep dive. Keep revising, trust your preparation, and keep pushing forward. We will see you next time.